We will be discussing fetal echocardiography in this session. I'm sure we come across a lot of suspected cases of congenital malformations in antenatal screening evaluations. This obviously creates a lot of anxiety to the parents. They want to know the significance of the findings and the prognosis. Knowledge regarding the congenital heart diseases and its prognosis gives us confidence and to answer these questions and counsel and guide the parents appropriately. Let us try to get an overall perspective as to why fetal cardiac screening is important. If we were to look at the IMR, which is the infant mortality ratio, which is an important indicator of the healthcare services in the area, IMR of Andhra Pradesh is 26 for every 1,000 live births. If we were to compare this with the neighboring state of Karnataka, the IMR is 15 in Karnataka. This gap suggests that there is still a considerable amount of infant mortalities happening due to infectious diseases in the state. When we are able to conquer these infections, and that is when the congenital malformations become a matter of public health importance. This is precisely what has happened in the state of Kerala. To reach single-digit IMR, they had to tackle the congenital malformations, which is a major part of, the major part of which is congenital heart diseases. So fetal echocardiography plays an important role in identifying children with congenital heart diseases so that the best possible outcomes can be given to the child. Numerous studies have shown benefit of antenatal detection in improving the outcome of children with congenital malformations. Let us come to the incidence of CHD. For every 1,000 live births with congenital malformations, congenital heart malformations are born. Out of these, 2 to 3 out of 1,000 live births is the incidence of critical congenital heart diseases. So precisely this is what is the target of fetal cardiac screening. It is important to detect this very critical congenital heart diseases. What do we mean by critical congenital heart diseases? Critical congenital heart diseases are the ones if these are not detected within the first few days of life, we are likely to lose these children. So these are the intervention is needed within the first few days of life. By definition, it is exactly this spectrum of critical congenital heart diseases that we need to focus on when we speak about screening of fetal heart. So basically, undue emphasis on less important findings such as small VSDs, echogenic foci, isolated LSVC, and abnormalities of the fetal aortic arch branching should be avoided. This data, if this data is to be extrapolated to Andhra Pradesh, daily at least 400 children with congenital heart diseases are born in our state. That is critical congenital heart diseases which are born in our state. This is what we have to pick up during our fetal screening evaluations. Plus, detection of critical CHD at fetal echo provides a unique opportunity for us to counsel the parents, prepare the family, plan the delivery, and provide the best possible outcomes for these children. So the basic fetal echo views. So let's come to these basic questions here. What is the crux of antenatal diagnosis, antenatal detection of fetal heart diseases? So is it detection of all cardiac malformations and to prognosticate them antenatally, or is it an opportunity to pick up malformed hearts and eliminate the abnormal pregnancies, or is it to detect the relevant conditions, counsel parents, prepare them for anticipated issues, plan delivery for critical lesions, and an option for termination in severe lesions? So out of these three options, it is the third option that is the correct option. That is the reason why we subject children to fetal heart screenings. So the basic fetal views are easy to obtain and help us to screen most of the congenital heart diseases. Everyone, even at the peripheral centers, should make it a point to obtain the basic views, which we will be discussing very soon. If there is a suspicion, referral to fetal medicine doctors to do a more comprehensive analysis and to rule out associated anomalies is needed. Then comes the role of a tertiary care pediatric cardiologist to counsel the parents regarding the disease, give them a complete perspective and long-term prognosis, and help them to make a decision in which in case of severe poor prognosis conditions, and confidence can be given in cases where the lesions are easily correctable. So let's come to the indications of fetal echo. So this can be divided into two: fetal indications and maternal indications. So let's come to the fetal indications first. Whenever there is an increased nuchal translucency done at 11 to 14 weeks of gestation, that is taken as greater than 3, there is an increased incidence of association of congenital heart diseases whenever the NT is increased. So the risk is 3 to 4-fold increased whenever NT is more than 3. So the second indication here is suspected congenital heart diseases on routine abdominal, the obstetric ultrasound. So this is the most important indication that we see, because this has been done already by an obstetrician where they have suspected a congenital heart diseases, and this provides the most positive, true positive findings are more in cases where the obstetrician has already suspected a congenital heart diseases on a echocardiogram. So the third one is whenever extracardiac birth defects are detected in an anomaly scan, in a TIFA scan. This is where the incidence of detecting a congenital cardiac malformation, which can be associated with syndromic children or with other congenital malformation, is more frequent. And then there is it is also indicated in risk of high output failure conditions. So these are few maternal indications where fetal echocardiogram is needed. Pre-gestational diabetes, which increases a 5-fold increased risk of congenital heart diseases. Phenylketonuria, which are very rarely seen. Maternal autoimmune diseases, which is again a very important indication, I feel, where there is anti-SSA Rho and anti-SSA La antibodies positive, and where we find bad obstetric history is very common in these conditions. And the main association whenever we get maternal autoimmune diseases is association with congenital heart blocks, which are very commonly associated with autoimmune conditions in the mother. And then family history of mother having a congenital heart disease, which increases the risk of the fetus by 6%, and paternal CHD, which increases the risk by 2%. And even if a prior child, a previous sibling has a congenital heart disease, this also increases the risk of the present pregnancy, and it warrants a evaluation for the fetal heart evaluation is needed in such conditions. So let's try to understand the various congenital heart diseases so that we are in a better position to know which are good prognosis, which have a decent prognosis, and which have a bad prognosis, antenatal detected congenital heart diseases, right? So whenever we speak about small VSDs and small ASDs, these all things actually are not of much importance whenever we are doing fetal cardiac evaluation, evaluations, because these do not come under critical congenital heart diseases. Even if the child has a small VSD or a large VSD in that case also, these are all correctable, easily correctable congenital heart diseases, and the parent should be reassured that the prognosis, long-term prognosis in such children is good. Overall, the condition, the shunt lesions do have a good prognosis. So the pre-tricuspid, the shunt lesions can be divided into pre-tricuspid and post-tricuspid. Pre-tricuspid, such as the ASD, PAPVC, and the TAPVCs. So the ASDs, which because the fetus already has a PFO, so a diagnosis of a ASD, which we sometimes see in the reports should not actually be made, because the ostium secundum ASD, because of the PFO flap that is present, is actually a physiological finding. Only when there is involvement of the primum septum, that is when the ASD is important, because of the association with genetic associations such as Down syndrome, which is associated with the primum ASDs. So post-tricuspid shunts such as VSDs, AVSDs and AP windows, these are actually little difficult. Actually the VSDs and the AP windows can be very easily missed on the fetal echocardiogram, and these actually are not of critical significance, and even if these are missed, it is okay, and it is like the prognosis of these conditions is good. So if it is picked up, the parents have to be reassured. Now coming to AVSD, which is the AV canal defects. The AV canal defects are very commonly associated with syndromic associations such as Down syndrome. So 50% of the cases of AVSD are associated with Down syndromes, and it requires a genetic evaluation whenever suspected, when these conditions are suspected. So coming to the second physiology, that is the VSD-PS physiology. This has the spectrum of tetralogy of Fallot, DORV with ventricular septal defect with pulmonary stenosis, and CCTGA with VSD with pulmonary stenosis. These are the three spectrums which we see in VSD with pulmonary stenosis physiology. The overall outcome of these conditions is reasonably good whenever the pulmonary artery is good in size and you are able to see a antegrade flow through the pulmonary artery. So whenever the pulmonary artery size, the main pulmonary artery size is good, we will be able to repair such children. Only when there is a pulmonary artery, when the pulmonary artery size, the main pulmonary artery size is small, or whenever there is total absence of pulmonary artery, these are the conditions where the surgical correction might not be might require multiple stages, and it might be a difficult condition to repair. But that said, there is a 25% association of this children with TOF with genetic anomalies, most common being DiGeorge anomaly and the Alagille anomaly and Down syndrome also in TOF children. So it does warrant amniocentesis to be done. So genetic testing is very important whenever we come across this spectrum of disorders. So coming to the transposition physiology, which is the transposition of great arteries and DORV with TGA type. So the prognosis of TGA is actually very good, and these are easily correctable conditions. If the pre-op condition of the child is good, the prognosis, the long-term prognosis of arterial switch operations is really good. So let me show you a paper that we have published in the ultrasound in obstetrics and gynecology in the year 2021. This is data from Amrita Institute of Medical Sciences, Cochin, where I trained. So it is from 2011 to 2019. In these 8 years, we came across 82 cases of transposition of great arteries that were detected antenatally. So out of these 82 cases, 64 went to deliver. 64 of them delivered. The rest of them, 15 of them did not continue the pregnancy, and there was one IUD in this case. Out of the 64 cases which delivered, 54 delivered at our center at Amrita, and the rest of them delivered outside. So what you can see here is, out of the 54 cases which were delivered at a tertiary care pediatric cardiac center, there is 52 people who survived. That is, only we lost 2 babies out of the 54 switch operations that we did. One was lost before surgery and one was lost post-op. So that is the prognosis actually of a TGA when antenatal diagnosis is done, and these cases, if they reach to cardiac centers in optimal conditions, we can provide excellent care, and excellent long-term prognosis of such children is possible. So I am sure actually even in our state we have wonderful centers who are taking care of children with congenital heart diseases, such as in Tirupati we have Padmavati Children's Heart Center, in our own city we have KIMS. So all these places are providing facilities for congenital heart disease patients now in this area. So then we come to admixture lesions such as TAPVC. So TAPVC again is a good outcome condition if the child reaches an optimal condition for the surgeries. So TAPVC is most of the time, if the pulmonary venous anatomy is good, the prognosis is good, but it is very challenging to pick up the TAPVCs antenatally. The reason being the pulmonary supply in the fetus is just 10%. The lung perfusion in the fetus is 10% of the cardiac output. So the pulmonary veins are very difficult to identify in fetal echocardiogram. And truncus arteriosus, again truncus arteriosus is a little difficult condition to manage, where the overall prognosis depends upon the patency and the adequacy of the truncal valve. So if the truncal valve is regurgitating and it is not a good valve, then the prognosis sometimes is not very good in truncus arteriosus cases, and there is a high association with syndromic associations with truncus arteriosus. Then we come to single ventricle physiologies. This is the very sector where complete correction of congenital heart diseases has still not been possible. So single ventricle physiologies is the area where multiple surgeries may be required. Usually 3 stages of surgeries are required, and even after the 3 stages of surgeries we cannot make it into a normal heart, and overall there is relatively the prognosis has been improving. They do have a lifespan of around 20 to 30 years, but these are the conditions where the long-term prognosis might be suboptimal. So coming to obstructions such as severe pulmonary stenosis, severe aortic stenosis, and coarctations. So these conditions are really good prognosis conditions where most of the time even surgical interventions might not be required, and transcatheter balloon interventions will be enough to tackle these conditions. So let's come to some miscellaneous problems such as Epstein's anomaly. The Epstein's anomaly is a spectrum where it can last from very minor to very severe spectrum. The severe spectrum can be even in antenatal period it can be fatal. The congenital heart blocks, here we see 50% association with maternal autoimmune antibodies in such cases, and antenatal steroids. There are few therapies available for congenital heart block conditions which are detected antenatally. So then we come to this issue of persistent LSVC. So whenever we come across cases with isolated persistent LSVC, this is actually a physiological variant. It is not a pathological variant in most of the conditions. What we have to rule out is associated congenital heart diseases, because whenever there is an LSVC that is noted, there is a high incidence of having other congenital heart malformations that can be associated with a LSVC. So these associated, when it is an isolated finding, it is just a physiological association and doesn't have much significance. So coming to abnormal branching patterns, again we come across a lot of fetal TIFA scans where abnormal branching pattern in the aorta is noted, where aberrant subclavian arteries or right-sided aortic arches are noted. Again, this condition, most of them are non-critical congenital heart diseases. Maximum what they have is vascular rings that are associated with them, and most of these vascular rings are easily treatable conditions, surgically correctable conditions. But only thing that has to be ruled out, they have a very small 5% association with genetic anomalies. So it is reasonable to get a genetic analysis done whenever we have abnormal branching pattern of the arch. Now coming to echogenic foci in the LV, which is again a very common finding that we see in most of the TIFA scan reports. So the significance of the echogenic foci is actually a very debated topic. So we come across, actually the incidence is 4 to 5%, and most of the times it is just a benign finding. So when do we give stress on this echocardiogenic foci is when we are having aneuploidy screen that is positive. Whenever there are multiple echogenic foci inside the heart, and whenever the intensity of the echogenic foci is greater than the intensity of the spine itself, this is when we give importance to this finding. Otherwise, most of the times it is a benign finding, and all that is required is ruling out other associated congenital heart diseases and giving reassurance to the family regarding this condition. So let's come to a few bad prognosis conditions. Hypoplastic right heart syndromes, hypoplastic left heart anomalies, severe Epstein's, TOF with pulmonary atresia and with bad pulmonary artery anatomy, and truncus with severe regurgitation. So these are the few conditions which I would like to highlight as which have relatively poor prognosis and long-term prognosis. They may require multiple surgeries, and even the surgical results might not be optimal in such conditions, and high association with genetic anomalies is seen in most of these congenital anomalies. So let's come to the basic fetal echocardiography views. These are the ISOG views. We should be, I'll go through each view now. So this is the situs view. So it is important to identify the situs. We need to first identify whether which is the left side of the fetus and the right side of the fetus. There are various modes which we identify the left and the right side. I'm sure gynecologist will be much more this one with the identification of the site, and once the left and the right side of the fetus is identified, we will focus on the stomach and the portal vein. Wherever the portal vein, the concavity of the portal vein is, that will show us the right side of the right side of the heart. So, and the stomach will point towards the left. So this is the situs view. Whenever we have dextrocardia or situs ambiguous, it helps us whenever we see in this view. So let's come to the four-chamber view of the heart. So this is a very important view where most of the severe congenital heart diseases can be picked up in this single view itself. So what all can we see in this view is, we'll be able to see that we will be able to see the four chambers of the heart. So whenever and the symmetry of the four chambers have to be noticed. If there is any asymmetry between the chambers, if there are any large ventricular septal defects, that will be obvious in this four-chamber view, that such as single ventricle physiologies can be very easily made out. Atrioventricular septal defects, which are the most commonly identified antenatal congenital heart diseases, are made out in the four-chamber view of the heart. The pulmonary venous, at least two pulmonary veins will be easily visible in this view, and that will help us to screen for anomalous pulmonary venous drainage. Plus we have to concentrate on the offsetting of the valves. So if we notice in this area, this is the attachment of the tricuspid valve, and this is the attachment of the mitral valve. You can see there is a slight offset within the attachment of the tricuspid valve and the mitral valve. The tricuspid valve is apically displaced slightly, and this is very important whenever we identify which is the right ventricle and which is the left ventricle. If we see the offsetting, we'll be able to identify the right ventricle and left ventricle, and it helps us to identify cases of the CCTGA cases where there is ventricular inversion, right? And this is the moderator band, which is a characteristic feature again of the right ventricle here. So this area is where the primum ASD will be required. If you find an ASD in this location, then it is a primum ASD, and that requires a genetic analysis to be done because it is very commonly associated with Down syndrome. This area is the PFO here, and that is the physiological association with the fetus. So this is an outflow tract view of the heart. So the outflow tract view of the heart, what we see here is, this is the ventricular septum and the mitral valve. We have to see the iotomitral continuity in this, and we will be able to see outlet VSDs. The outlet VSDs will be visible in this area of the heart, and this is the mitral valve, and this is the continuity of the iotomitral continuity will be seen in this view. So this is an important view when we are evaluating tetralogy of Fallow. This is the view where we get the outflow tract view. Wherever we get a conoventricular VSDs, we'll be able to identify in TOF cases. So this is a 3-vessel view of the heart, where we'll see the left and anterior is the pulmonary artery, the center one here and slightly posterior is the aorta, and the third one and to the most posterior, to the right and most posterior is the SVC. The aorta is seen to the left of the spine here, right? So this shows that it is a left-sided aortic arch here, and this arrangement of the vessels is seen in 3-vessel view. This is a 3-vessel tracheal view, where we see the ductal arch and the aortic arch, and they submerge to form the isthmic area, and this is the descending thoracic aorta in this area, which is a very important view which we will be discussing in the next few slides. So this is a 4-chamber view of the heart. Here what we are seeing is the aorta, this is the spine here, and you can see that the aorta is slightly to the left of the spine, which is the normal association. Whenever we see a right-sided aortic arch, we will either see the aorta will be slightly shifted in the center, or it will lie slightly to the right of the spine. So this is the area behind the heart which I am focusing currently. This area, if there is a confluence vein present in this area, this signifies that there could be an association with a TAPVC. Here we are seeing the ventricles which are symmetrically located. This is the moderator band. The highly trabeculated ventricle is the RV. There is a slight offsetting seen here, which again signifies that this is the tricuspid valve and this is the mitral valve here. So this is the 4-chamber view of the heart, where any large VSDs and all can be easily made out. So here what we are seeing is a large defect here. So this again is actually a flap valve. The flap is towards the left atrium. This is the left atrium. This is the aorta. This is the left atrium. The flap is towards the LA. So this is again a normal, the patent foramen oval that we are seeing here. So in this image what we have shown is there is an asymmetry of chambers. The RV is large and the LV is smaller in size. So what are the associated diagnoses when we think about this condition? We have to always think about, to rule out coarctation of aorta and TAPVC whenever we come across such asymmetry in the ventricles. But this can be a physiological association in late 2nd and 3rd trimesters, where the RV is actually the systemic ventricle in the fetus, so it is sometimes large in size. So whenever there is a suspicion, it is always important to subject these children postnatally for echocardiography to confirm coarctation of aorta or TAPVC, because even if coarctation is suspected antenatally, there is only a 50% chance of it being right, because coarctation, the isthmus is the blood flow through the isthmus is less during this one. So here what we see is the LV is very small in size. You are seeing the mitral valve also very small in size. So this is a hypoplastic left heart that we are seeing in this picture. So this is showing echogenic cardiac foci. So this here is a bright shadow. This is the spine. We have to compare the shadow to the spine, and the multiple echogenic foci can be of significance, especially when aneuploidy screens are positive. So this is again the outflow tract view. Here we are seeing the VSD. This is a typical case of tetralogy of Fallot, where you see the outflow tract and you see that there is a defect in the outflow tract. So this is a 3-vessel VT view, where we see that the pulmonary artery and aorta are in the same direction. The flows are in the same direction. In this, we are seeing that there is a smaller aorta compared to the pulmonary artery flow. So this is typically associated with, this is a flow reversal, so it is associated with interrupted aortic arch. And this one, where we see a small aorta compared to the pulmonary artery, is characteristic of the either of aortic stenosis, or we will see this in conditions where hypoplastic aorta is present or coarctation of aorta is present. So in this picture we are seeing that the pulmonary artery is relatively small when we compare it to the aorta. This is again a characteristic feature of tetralogy of Fallot. Here there is a retrograde flow into the pulmonary artery, which shows that it is a absent, where the flows are absent, antegrade flows in the pulmonary pulmonary vessel are absent, and hence it is filling retrogradely from the duct. So this is one is a single vessel that is visible in the three vessel view, and this is a very important picture which helps us diagnose TGAs. It is a characteristic feature where single vessel is visible in the three vessel VT view, and because of the overlap of the aorta and because they are anterior posterior and parallel to each other, so they will overlap, and hence only single vessel will be visible in a TGA. I think some videos were there which are not playing. Yeah, so I would like to conclude the talk. Yeah.